Good evening all for today's episode of Gurukul Pathshala. Today, as having a month-ending episode, we are having an expert talk which is followed by the quiz which is liked by each and everyone and conducted by Dr. Prashant KARIYA. So for today's episode, I welcome our President Dr. Jhankhana Sanghavi Madam for her welcome address.
Thank you, Dr. Nehal. I welcome today's expert speaker, Dr. Shridhar Joshi sir. I welcome Sandeep Trivedi sir, Dr. Nehal sir, Dr. Nehal, Dr. Lata sir, and Prashant KARIYA, and all attending. Shridhar, we are very, very eager to learn something very important from your expert talk, Shridhar sir. Your opinion about fits, feints, and funny turns. So we are vigorously waiting for your expert opinions and expert output. And quiz is always a feast to all of us. So I welcome Dr. Prashant KARIYA for his quiz also. And not taking much of your time, over to Dr. Nehal, please.
Thank you, madam, for the wonderful address. Thank you, Sandeep bhai, for being here and always letting the students know that the learning never ends. Yes. So I welcome Lata, the Chief Program Coordinator, for introducing the today's expert.
Thank you, ma'am, for your kind words. So today's expert is Dr. Shridhar Joshi. He is pediatric neurologist at ND Desai Medical College, Nadiad. His expertise is in complex pediatric seizures and strokes. And he has got a very funny topic, fits, feints, and funny turns. A video is worth million words. So stage is all yours, sir. Shridhar, sir.
Alkashoni madam, welcome.
Sir, please unmute.
Thank you.
I'll just share the screen.
Yes.
Yes, sir. Are you able to share or should I make you a host? Yes, you are able to share.
Is it visible?
Yes, it's visible and full screen.
It's visible.
Yeah, I think, but my Bluetooth is not. Maybe for new also fine.
Their slides were visible earlier. They were full screen.
It is visible, na?
Yes.
And I'm
Yeah,
audible.
make it full screen. Yeah,
Yes,
yeah,
you are
yeah.
audible.
Yeah, sure. Then we'll start. Good evening for the gracious welcome. So without further ado, we'll start the topic: seizure mimics, fits, feints, and funny turns. So this will be the schema of my presentation. We'll see how to differentiate seizure mimics from seizures clinically, and we'll see some examples across the age spectrum in neonates, infants, children, and adolescents. So although we have a quiz, I would like the participants to participate actively and answer in the chat. My chat is open and I will be reading your answers. So there are videos and you need to make a diagnosis from the videos and the little history which I provide. There are no wrong answers. It is just learning. So please be active and let's make it a dialogue rather than a monologue. So some theory, how do we differentiate seizure mimics from seizures clinically? So they usually occur in neurotypical children, except stereotypies and paroxysmal movement disorders, which may occur in children with autism and paroxysmal dyskinesias. They usually occur in bored or sleepy state. They are stereotyped episodes, except non-epileptic seizures, which are non-stereotypic. That is, they will have different simiologies at different time. They are usually considered seizures and are treated with anti-seizure medications. However, there is no response. There is no ictal correlate if EEG is done in these children. mind you, we have to do a video EEG for these children to capture the event and see it for a ictal correlate. And majority of time, even we see the children after 2 to 3 consults, and what makes us make the diagnosis is a video. So that's why the thing, a video is worth million words. Okay, so we will see all the cases which we diagnosed. Majority of them, 90% of them, were diagnosed without a EEG or an MRI, or if they were done elsewhere and not by us. So we'll start with neonates. So these are 2 neonates, 15-day male child, paroxysmal events at sleep initiation, relatively easy, left focal, right, and then both hands. What was disturbing for the parents is that the father is a known case of juvenile myoclonic epilepsy, and father had this event since 15 years of age. So the father thought that my child is also having similar epilepsy, and they brought the child in absolute frenzy. So these are the events you can see occurring at sleep initiation, left focal, relatively easy one. Anyone with the answers in comments?
So one answer is benign neonatal.
Yeah, it's a
Another
benign neonatal
is
sleep myoclonus.
sleep myoclonus.
Sure. So this is a relatively easy one. So it's a benign neonatal sleep myoclonus. Now coming to case number 2, 20-day male, stiffening of limbs or startle as described by parents since day 1 of life. He was in NICU, loaded with 3 anti-seizure medications, and was also on a cocktail of pyridoxine, pyridoxal 5-phosphate, and folinic acid, considering the child to be drug refractory neonatal epilepsy and a genetic epilepsy. So these were the movements which were there, and the startle was usually to sound or the maneuver which I am doing currently. So I'm tapping the nose, and you can see the jerk. Yeah. If you want to see, we can see the video again. So I'm tapping the nose, and you can see the multifocal clonic jerks. Yeah.
Somebody has answered hyperpepsia. I don't know. I think
Yeah. It is a hyperexplexia. So
hyperpepsia.
it is.
That is just a spelling mistake. Otherwise, it's okay.
Yeah.
Hmm.
So this is known as hereditary hyperexplexia or neonatal stiff person syndrome. So these children are usually stiff. And what is the treatment? Can anyone answer? He has failed 3 anti-seizure medications, phenobarbital, levetiracetam, and phenytoin. So what do you want to give? Treatment of choice, completely treatable.
Just waiting for the answer, sir. B12, vitamin B12, somebody has answered.
Huh? Sorry?
Vitamin B12.
Vitamin we have given already. No response.
Yeah.
B12, no. Thiamine, no.
I mean,
Anyone? So the treatment is clonazepam and vigmanomanvir. So what is vigmanomanvir? So if the child is having such startle episodes, you hold the child in a flexed posture with with the limbs and the trunk flex. So this is what we call a vigmanomanvir, and this aborts the startle. And one drug which we should give is clonazepam. They require it till at least I think 3 to 5 years of age. But only a load of clonazepam like 0.01 milligram per kg per day up to maximum 0.1 milligram per kg per day should be enough. So we need to be aware in neonatal neurology. we do see a lot of these consults. Sleep myoclonus, almost everyone picks up, but this is something which we should all know. So we should be aware about the nose tapping test, the treatment of choice being clonazepam and the vigveno to avoid refractory such spasms. Some of these spasms can be very severe, which can also lead to laryngeal spasm, and these children may actually have a respiratory distress. So this is a slide. We can take a screenshot. So basically, this is a syndrome because of defects in this glycine receptor genes. So as we all know, glycine is an inhibitory neurotransmitter. And in this mutation, the glycine receptors are dysfunctional. So there is a dysfunction of inhibitory neurotransmitter, which leads to excitation. So whenever we tap the nose, because of excitation, the child goes into a startle. Okay, so majority of them, I have normal EEGs, normal MRI. They fail anti-seizure medications, they fail B vitamin trials, and they only respond to clonazepam and vigveno. So this is one of the condition which all the pediatricians and neonatologists should be aware of. This is another neonate with paroxysmal head and eye events. So this is very classical. Just see both the videos. You can see head moving right and left and see the eyes. See properly, see the eyes. Yeah. See, you can see the small jerks in the eyes. These were both full-term infants, normal weight, no perinatal asphyxia, and had these movements multiple times in the day, mostly in before feed state. So before feeds, they would have this paroxysmal head and eye movements. So this is the seizure mimic or the funny turn which the child is having. The name is paroxysmal head and eye movements. I need to know from the audience what are the differential diagnoses you will suspect in such cases, because these are very pathognomic of disorder which we'll be discussing. So any ideas?
So we have one answer, Sandifer.
Sandifer is usually for a infant with gastroesophageal reflux. These children are neonates. Yeah,
Opsoclonus, another answer.
Opsoclonus is a good guess, but we are still discussing neonates. Opsoclonus is a movement disorder of an infant 6 months to 2 years of age to 5 years of age. This is a neonate, 15-day, 20-day neonate with paroxysmal head and eye movements. So I'll let you see it again and I'll reveal the diagnosis. Just remember these movements very carefully. If you see those, you can actually make a diagnosis. It mimics opsoclonus, but there are also head movements, head jerks. So this is classically seen in two syndromes. One is glucose transporter 1 deficiency syndrome, and one is pyridoxal 5-phosphate dependent epilepsy. So you have these two differentials. For GLUT1, what you can do is you can do a EEG in a fasting state, which will be abnormal. And when you do a EEG in a fat state, it will be normal. Whereas PNPO deficiency will show EEG, which is abnormal in both fasting as well as fat state. The treatment for GLUT1 deficiency syndrome, it's basically a glucose transporter. So glucose will not be able to reach the brain. So we have to give an alternative source of energy to the brain, which will be ketone bodies. So the treatment of GLUT1 deficiency syndrome is ketogenic diet. And the treatment of pyridoxal 5-phosphate dependent epilepsy, as the name goes, is pyridoxal 5-phosphate supplementation. It's available as a tablet formulation by name Tab Firofem. The dose of pyridoxal 5-phosphate is 30 to 50 milligram per kg per day in 3 divided doses. Ketogenic diet, you will have to contact a metabolic dietitian or a pediatric neurologist who are well versed with providing the diet. But yeah, both are treatable, and with this treatment, they can have near normal developmental outcomes. So here we finish neonates. So we show sleep myoclonus, which all of us usually recognize. I want you to know two other movements. First is this hereditary hyperexplasia, treatment being clonazepam and vigveno, and this paroxysmal head and eye movements with these two pertinent differentials. All these three diseases are very well treatable, and with a good eye, the mind can know what we have seen. Okay, so we now jump on to infants. So as usual, we'll start with the easy case and then we'll progress further. So this is a 8-month-old female with normal perinatal history and development. She is about to sleep and she is having this movement. And this is a 5-month male with normal perinatal history and development again, but again he is having these movements. Just see again. Yeah, you can see she is almost like stiffening and the jaw is going. And even in this female, you can see she's active, alert, and
So we have two answers: West syndrome and sleep myoclonus.
I will not show you any videos again. Don't worry. So it's not sleep myoclonus. Okay, West syndrome. Actually, very good that they were referred to us as West syndrome. Both the neonates were referred to us as West syndrome. But as I told you, that see the history I'm giving you. I told you the first slide. Usually, this fits, faints, and funny turns occur in the child who is developmentally normal. West syndrome, we know they will have developmental regression with onset of this. So actually, it is not West syndrome. It is shuddering attack, as Dr. Mala Pujani told. Okay, it's a shuddering attack. You can see as if a cold water is spilled on the back of the child and the child is doing this movement. This classical shuddering. Just see this child. You see that? As if some cold water is poured on him. He is active, alert, playful, normal development, normal head circumference, no perinatal risk factors, nothing. So that's what I want to inculcate in you. That once you see a video, you will think of all the worst diagnosis possible in the world. West syndrome, epileptic encephalopathy. Okay, but always remember, if you have normal birth history, normal head size, normal development, and normal neurological examination, it is a mimic until proven otherwise. You may need us for EEG or a video EEG, but even if you are in a periphery where pediatric neurologists are not available, just observe them. Tell the parents that we will do a developmental surveillance. We'll look at the head size, we'll look at the growth, we'll look at the development. And if it is normal, then obviously the child is just saying a seizure mimic. Because if it's a West syndrome or an epileptic encephalopathy, they would surely regress. Okay, so just give them 1 to 2 weeks, observe, tell them to make videos and send you. What happens is usually these parents don't make videos and they just go to doctor and tell, Chokro jhatka mara hai. He just jerks. So at 5 to 6 months, what our mind thinks is jerks, myoclonus or West syndrome or epileptic spasms. Till the time you don't see the video, you will clinical diagnosis will be West syndrome and you are not wrong in that. But always ask for a video. That's why the importance of videos in this talk. Okay, this is a doctor's child. See, this child is a febrile infant with new onset twitches. Okay. You can see mother support. He's so this again, see the face. Just look at the face. Yeah, see, you saw that? I'll show you another video. Again, the child. You can see the child is almost drowsy, playing with his grandfather. Feverish, just given paracetamol. Look at the end movement. You have to be very observant. Yeah, see that twitch in the mouth? His third video, he is asleep. Yeah, the twitch. Did you observe that? And the mother, you can see in the background, she is already making a call to a pediatrician that I don't know what my child is having. Complete panic in the house. I got a call at 11:30 in the night for this child. That should they bring him to the casualty or not? Again, normal birth, normal development. As you can see, the head size appears normal, the growth appears normal, and is febrile. So, and he's asleep. So all the characteristics of seizure mimic I just told you. So what do you think? What is the diagnosis? Should we call the parents at midnight or not? Any video you want to see again? You can let me know. I can show because of the time I have just trimmed the videos. but I think you are able to make out the videos and the movements which I need to show you.
Somebody wants second video, sir, Dr. Aparajita.
Yeah,
I think
sure.
it will be
You can
repeated.
see that. Just see the child and observe the mouth. You observe the twitch of the lower lip. Yeah. Or you can observe this also. It's similar only. You can see. Just observe the mouth. Yeah. See, you saw that? So he's febrile infant. And which kind of movement is this? It's a muscle jerk or myoclonus. So this is what we call as febrile myoclonus of infancy. Okay, just like febrile seizure in which you have a GTCS, you can also have febrile myoclonus. Similar characteristics occurs in the same age range as febrile seizure, 6 months to 6 years. And this is relatively frequent but under-recognized. Okay, and some of them have also coined the term para-infectious myoclonic jerks for this condition. It is known as well as 1960. As early as 1960, they have been recognized. So not all fever events are febrile GTCS or the simple febrile seizures. You can also have febrile myoclonus, and we just counsel the mother that these are normal movements. Once the fever subsides, they'll go away. No treatment required. Just give paracetamol, and we did not do any EEG or MRI. So this is what we call as febrile myoclonus of infancy. Now there is another child. This was referred to us as West syndrome. Okay, but again, see the video. See again, you can see she's yawning. You can hear the grandfather saying that the child is getting feared. You can also hear Dikirina Babu Harka because the father also had such events. So this was referred to as West syndrome. But we did a video EG for the child, and during this event there was no either in the interictal period there was no hypsarrhythmia, and during this event there was no ictal correlate, and you can see the child is sleepy. So this is a relatively tough call. Looks like epileptic spasms, but this is what we call as non-epileptic myoclonus of infancy or Federman syndrome. Okay, so this is very commonly known as non-epileptic myoclonus of infancy and early childhood, or known as Federman syndrome. Usually occurs between 4 to 24 months age and between 5 to 8 months in most cases. The most common movements are extensor muscle jerks, head titubation with rotation, axial spasms, and nods. Okay, and some of them may even have delayed psychomotor development. But however, none of the children show abnormal movements accompanied by a EEG pathological activity. If this was an epileptic spasm, EEG could have showed a epileptiform discharge, but it was not there. So it's very important to recognize this. And again, as I reiterate, always ask these things. If there are no perinatal risk factors, there is no developmental stagnation or regression, head size is normal, and there is normal neurological examination, this is a seizure mimic and not a seizure. That you could at least tell your patient. You could leave the exact diagnosis to a specialist opinion if required. And even if you don't do it, you can always tell them that it's a seizure mimic, nothing to worry. We'll observe and do a developmental surveillance. So this is known as Federman syndrome or non-epileptic myoclonus of infancy. And now you can see this is a 2-month-old child, and since 6-month-old child, and since last 2 weeks he's having this paroxysmal events. He has history of neonatal hypoglycemia and had an NICU stay for 7 days. See the movements. He's awake. Yeah. So what is this? This is relatively easy. Anyone? History of neonatal hypoglycemia since last 2 weeks he's having this paroxysmal events. Mostly occurs in hypnopompic period, that is when he gets up from the sleep. Occurs in clusters, 5 to 6 spasms per cluster, or 5 to 6 such jugs per cluster. Yeah, so finally you got a West syndrome. Yes,
West
this is,
syndrome, yeah.
this is epileptic spasm. What need to show you is this. Again, observe the chin of this child. Yeah, you can see something like going inside, like he's supposed to vomit. So this is what we call as red sign. This is a classical sign which is described for subtle infantile spasm. So this is what I showed is classical. Before the first week, this child had only this twitching of the lower lip with the twitching of the mentalis muscle. So if you have a perinatal risk factor child, and if they have this twitching of this mentalis muscle, which occurs in the hypnopompic period, occurs in clusters, like 5 to 6 events per cluster, not a singular event. Okay, with an perinatal risk factor, just this child requires a EEG, and EEG showed hypseridemia, and we started the child on injection ACTH, that is steroids, and then the child had a resolution of epileptic spasms. So I need you to remember this red sign, which is a sign of subtle infantile spasm. Even the previous febrile myoclonus infant, febrile myoclonus had a red sign, but remember that child was neurodevelopmentally normal and had no perinatal risk factors. In a child with perinatal risk factor, this is considered a classical sign for epileptic spasms or infantile spasms. This is 1.5-year-old infant, male, no perinatal history, normal development, and he is having this paroxysmal event since 1 month, and he is treated elsewhere with 3 anti-seizure medications, valproate plus levetiracetam plus clobazam. He has no response, normal EEG, but repeated abnormal elsewhere. MRI is normal. At least this child had at least 2 MRIs which were normal, and EEGs which were reported abnormal elsewhere, but when I reviewed the EEGs, they are completely normal. So I told parents to make a video and show me. So they were being treated as a tonic seizures. So observe this video. So he's playing. You can see this seizure-like posturing of the limbs and tonic posturing of the hands. So you can see he's playing with his big brother, and he's having these events where he's squeezing his genitalia and he's having tonic posturing of the both upper limbs, which are being treated like a tonic seizure. So do you think it's a seizure or a seizure mimic? Calcium levels were normal.
Yeah,
This is
2%
what we call as
self-gratification.
Yeah, so this correctly answered. This is self-gratification or infantile masturbation. Okay, so self-gratification disorder. So what is the treatment? Would you continue any of the anti-seizure medications, or you will stop it? What would you do?
Reassurance. Personal answer.
Great. So reassurance is a treatment. Very good. So this you can see. This is a very good review on childhood gratification syndrome. Just to reiterate the fact that this can occur in infancy, and some of them may also go on to develop in childhood. One of the common thing which I have observed in my clinical practice is majority of these infants and children are iron deficient. So whenever they are alone, bored, just about to fall asleep, then they will have this squeezing of the genitalia and rocking movements just to please themselves. And this is known as self-gratification disorder. Usually they have female preponderance. They may have early onset. They may have rigid posture with genital manipulation, associated stereotypical behaviors. Some of them may also have sweating and autonomic features like sweating, facial pallor, facial fluffiness, like just like an orgasm which we have. It may have variable frequency and duration lasting for few seconds or maybe lasting for hours and may occur multiple times in a day. And the point which we need to understand is they will have intact consciousness and responsiveness. As you saw, as soon as the elder brother told Golu Molu Bacha, he started crying. Okay, so this is suggestive of an intact responsiveness. So no generalized movement will occur with intact responsiveness, especially a seizure. So this was never a seizure to start with. But again, when you hear parents, બાળક આખો ટાઈટ થઈ જાય છે અને આખો ઉપર થઈ જાય છે, મોઢામાં પરસેવો પરસો થઈ જાય છે, and these infants are there, they may sometimes pass urine during this episode, and they may just treat it as a generalized tonic seizure with what this child was treated as. Okay, so be very skeptical in judging these movements as seizures and reassure the parents. So now we come to the last infant case, 1-year-old child with eye jerking, irritability, motor regression, and sleep disturbances. And he underwent some surgery that you will tell me which surgery, but first of all, see the movements. See the eyes. You got it or any, you want to see it again?
So one answer has come, neuroblastoma.
Very good. And what is the eye movement?
Opsoclonus myoclonus.
Yeah.
Opsoclonus myoclonus.
Yeah. So this is what operation is done. What do you think? Which organ is removed? Which cavity is opened? What is the most common site for neuroblastoma?
Adrenal, somebody.
Yeah. So this is abdomen, and you can see this is the ileum. You can see the aorta, and you can see the neuroblastoma, which is para-aortic lymph node. Are you able to observe this green arrow? This is a neuroblastoma, and you can see a calcification puncta over here. These are usually calcified tumors. So what is the treatment? Remove the tumor, and after that, you have to give immunotherapy with dexamethasone, IVIG, and rituximab. And if the tumor shows anemic amplification, then you might require a chemotherapy with cyclophosphamide, etoposide, and daunorubicin. Okay, so when you see a child who has motor regression, eye jerking, irritability, and sleep disturbances, the lesson over here is don't do MRI brain, do a CT thorax, abdomen, and pelvis. Okay, because the answer would be found in the chest, abdomen, and pelvis, because this neuroblastomas occur along the sympathetic chains which are running in the thorax, abdomen, and pelvis. So what happens whenever you see a neurological case, your mind jumps to let's do MRI brain. But when you see a case with opsoclonus, myoclonus, ataxia, and sleep disturbances with irritability, these babies are described as Velcro babies. They're extremely irritable. They just cling on to their mothers. So do a CT thorax and abdomen, find the tumor, remove it, give immunotherapy. If the tumor shows anemic amplification, give chemotherapy. Okay, so the diagnosis is opsoclonus myoclonus ataxia syndrome. This is a paraneoplastic omas. It could also be infectious sometimes. So you have to take care that if sometimes it may be post-infectious also, but 90% of cases occur paraneoplastic. So find the tumor in the chest, thorax, and abdominal cavity. This is a 5-month-old infant with motor delay. Also had some delayed cry. However, no neonatal encephalopathy, no NICU stay. And he had these paroxysmal events which are lasting for 1 to 2 hours. He is playing. You can see the neck twisted to the left side. You can see the uprolling of eyeballs. So the neck was rotated to left side. Then there is some rotation extension towards back. And you can see some uprolling of eyeballs which are lasting for hours. Okay, let me give you a clue. If this child was treated with, let's say, metoclopramide, then what will be your diagnosis?
So we have two answers, ITS. Both are ITS.
Okay, so this child has no knuckle hyperpigmentation, no anemia. He is a child from South India, where I did my DM. So they are usually non-vegetarian peoples. So there ITS is almost non-existent. I had seen one case in my 5 years of DM plus assistant professorship in CMC Vellore, and that was also a child who had migrated from Bihar. So very unlikely over there. But yeah, you can see the uprolling tonic upgaze of the eyes. What will be if this child, let's forget the history, if this child had vomiting and received metoclopramide, what will you think in this child?
So we have few more answers. Status dystonicus, dyskinesia, dystonia, tardive dyskinesia, oculogyric crisis.
Yeah, so if the child was given metoclopramide, you would think of a oculogyric crisis. So this oculogyric crisis like reaction without drug is what we call as paroxysmal tonic upgaze of infancy. Okay, so this you have paroxysmal tonic upgaze of infancy. You have neck deviation, which is a part of dystonia, correct? And you have retrocolis. You can see the neck going backwards. So you have and you have motor stereotypies. You can see the stereotypic leg and hand movements. So this is what we called as a complex hyperkinetic movement disorder. Or if you cannot remember this word, you can just remember paroxysmal tonic upgaze of infancy. And the most common differential in this infants is monoamine neurotransmitter disorders. So they may have may have a block in pathway which forms your monoamine neurotransmitters like dopamine, epinephrine, norepinephrine, etc. So this is what we call as paroxysmal tonic upgaze of infancy, which we need to differentiate from oculogyric crisis. So oculogyric crisis is usually drug induced, whereas PTU is not drug induced. And you can remember these things. They have normal horizontal eye movements. They have diurnal fluctuation of symptoms, as we all know, like an dopamine, which is a diurnal variation. Dopamine is synthesis decreased in the evening. So they may have more of these movements in the evening. They are frequently relieved by sleep and they are exacerbated by febrile illness. So whenever you have this thing, just think of paroxysmal tonic upgaze. They may occur in infancy just like that. But if they have a motor delay, like in this child, always work them up for monoamine neurotransmitter disorders. So the investigations you can do in this child are serum prolactin, which is usually increased. And then you may have to go for CSF neurotransmitter levels. And finally, the diagnosis confirmed on clinical exome or whole exome sequencing. That is genetics. However, if the child is normal developmentally and no parental risk factors, you can just label this as paroxysmal tonic upgaze. And if it lasts for hours, you can give anticholinergic drugs like trihexyphenidyl, and this may resolve. And if it is drug induced with a drug like metoclopramide, you need to stop the drug and give antihistaminic medications like chlorpheniramine maleate or Benadryl. So when you have this PTU, think of three things: monoamine neurotransmitter disorders, some channelopathies, and even infantile Angelman syndrome may have this presentation. However, the classical presentation is all this happy puppet phenotype with ataxia, microcephaly, and all. But just to remember, Angelman can also have these movements. Okay. And this is a case which is a proven L-amino acid decarboxylase deficiency. And I just wanted to present this case to show you another movement. Just see this child. I lift the eyelids. And you will see paroxysmal tonic down gaze. So there is, if you have paroxysmal tonic up gaze or paroxysmal tonic down gaze with intellectual disability, microcephaly, failure to thrive, tone abnormalities, think of monoamine neurotransmitter disorder, the most common being L-aromatic amino acid decarboxylase deficiency. So I just wanted to show you the video of tonic up gaze and tonic down gaze. So you are aware of the entire spectrum. So this is paroxysmal tonic down gaze. So take a screenshot. These are developmental movement disorders in infancy. Why do we call them developmental? Because it indicates that the brain is myelinating. Whenever the brain is myelinating, there will be some leakage of currents. And this leakage of currents will give rise to these paroxysmal events. But what we need to remember is they will have normal perinatal history, normal development, normal head size, and normal neurological examination. So the one we did not discuss is Fasman's Newtons because I did not have its video. But yeah, it is easily available in YouTube and you can see the video. It's usually a triad of paroxysmal head nodding with nystagmus and torticollis. Once you see it, you will never forget. But what is important is this: you have to tell the parents when it will resolve. Okay, so like something like shuddering attacks may resolve up to 4 years. So if a child comes to you at 6 months, you tell them that it will stay till 3 to 4 years and don't worry, it is normal. So always keep this diagram handy in your OPD and you can explain this to the parents. So now we go to the last exhibit, which is children and adolescents. So this is a 8-year-old female child. She had 4 episodes of fall and the last episode was in a mall. So in mall, because of CCTV camera, we could record the video. So just see the video. She is standing. This is the child with the father. And then she is rolling of eyeball and fall. And some tonic posturing of the lower limbs. Want to see it again? You can see the child is standing. Everything is fine. Then she is trying to hold the table, uprolling of eyeballs, some, and then fall. And then some tonic posturing of lower limb. What is it? Fit, faint, or a funny turn? Diagnosis. You can ask me any question if you want in history. I can tell you the history also.
We have 2-3 answers: syncope, seizure, atonic seizures.
Okay. So the ones who have written seizure or atonic seizure, why do you think it's a seizure? What are the points for seizure? And those who have written syncope, what is the point for syncope?
Two people have asked 2 questions: any trauma after episode, and second, recovery time.
So there was no trauma episode and the recovery was almost immediate within 30 seconds. She was sprinkled some water and then she woke up, and when she was asked what happened, she told that she had some blackout in front of her eyes. Her head was spinning. She felt some gurgling sound in the abdomen and then she fell. And one of the classical history which no one asked is all these episodes of fall happened when she was in standing period, when she was standing for a almost prolonged time. So that's why this is syncope and not seizure. Okay. But what happened to this child, I'll tell you. So my question, usually the people ask that they tell that if there's a tongue bite, then it's a seizure, and if there is no tongue bite, it is a syncope. But you can see this is a child with syncope and had a tongue bite or lip bite. Okay, so there is nothing like tongue bite, seizure, no tongue bite, syncope. This child, basically what happened, someone did a EEG and this EEG was reported as generalized epileptiform discharges and this child was started on levetiracetam. But basically if you see the EEG, this is classical slip spindles and these are what we call as mitten waves. No need to go to complexity of the EEG, but this is a normal variant in EEG which was reported as abnormal. So this was, the child required a ECG, but ultimately end up with a EEG and was started on levetiracetam. Now the fact of matter is after starting levetiracetam, she had 3 more events. Why? Because levetiracetam increases the QT interval and it worsens the syncope. So the child required ECG and not EEG, and that led to the problem. So always treat the child, not the investigations, and trust the history. All the events occur in awake state, all events in standing. This is usually syncope and not seizure. Okay, now this is a I hope I'm clear. This any clarifications in the previous case? So this is a 10-year-old male child. He was referred to as having eyelid myoclonia. Just observe this side. See these eyes. You can see I'm telling him to do some complex movements with the fingers, and it's stopping but temporarily, and then again it's starting. You can see it again. Yeah. See, as soon as he doing the movement is okay, and then again he starts seeing me, then again he does it. Normal birth, normal development, some learning disability, poor in English and maths. Lot of scolding at home and at tuition.
One answer has absence seizure.
Absence seizure.
Another person dyslexia.
Yeah, dyslexia is a diagnosis, but what is the eyelid movement? Eyelid movement is not dyslexia. And his absence seizure will have absent consciousness. He is able to answer to me. If you see, he is making eye contact with me. See, and then he will again go back to do these eye movements. So actually he was referred to as eyelid myoclonia with absences, but this is not eyelid myoclonia with absences. This is something what we call as motor tics. These are eyelid tics. So it responded to cognitive and behavioral intervention in tics. So the classical thing to ask in tic is the urge cycle. You have to ask, okay, do you have the urge to do this movement? And when you do the movement, do you feel relieved? So if you ask this thing, they will usually have. If not, what you can do is you can see the distractibility. If any movement is distractible, okay, then it is usually a tic or a stereotypy. Stereotypy is something which is occurring same again and again, whereas tic may not occur same again and again. It may have a fragmented quality. And another thing to remember is tics are usually either motor or vocal. You might have heard some of your teachers or school teachers who are regularly clearing the throat. They may have vocal tic. You might have seen Salman Khan is doing this nose movement. He is having a motor tic. Okay. Some of the teachers, if you see, they may just have the shoulder shrug. They may also have motor tic. So these are tics. Nothing to do. And if they are hampering his daily life, then you can send them to child psychologist and they do something which is known as CBIT, that is cognitive behavioral intervention in tics, and this may stop. If they are refractory, then you may need medications like tetrabenazine or wild tetrabenazine. So this is, take a screenshot. If the tics are chronic, that means lasting for more than 18 months. If you have both motor and vocal tics together, and it is hampering your quality of life, your studies, your play, your time with your family, then it is known as chronic tic disorder or Tourette syndrome. And in Tourette syndrome, you may start with behavioral therapy, but however, they don't work. And then you have to go to pharmacotherapy, which is the medications which I have shown over here. If you have not seen, you can see movie Hitchcock, which has classically described the case of Tourette syndrome. Okay, so this you should know. If the tic is more than 18 months, has both motor and vocal components, and is disrupting the quality of life of the child, then it is a Tourette syndrome, and this requires behavior plus pharmacotherapy. And this is a case of a 24-year-old female child from PGI Chandigarh, and she had this movements of the eye and shoulder. So she was treated, and she had only had the movement of the left side of the face and the shoulder. You can see it again. Yeah, the jerk, and then the left side of the face undergoes a tonic spasm. If you can observe the left side of the face clearly, see there is a tonic spasm of the left side of the face. And this is a EEG occurring at that time. normal birth, normal development. She was on 3 anti-seizure medications with no response.
So we have an answer, hemifacial spasm,
Yeah.
myasthenia gravis. So we could have a
Yeah,
spasm.
so this is a hemifacial spasm. Myasthenia gravis will have ptosis and ophthalmoplegia, will have a diurnal variation. This is classical hemifacial spasm. And again, the clue is no response to anti-seizure medication. So this child, we gave botulinum toxin, and then she was okay. One another thing to see in hemifacial spasm is the eye is contracting down and the this eyebrow is going up. If you could see, the eye is going down and the eyebrow is going up. Can you appreciate? Again, see, this is a very important sign in hemifacial spasm. The eye is going down and see the eyebrow is going up.
जो प्लेट्स क्यों डाला था फ्लैट में अच्छा
The eye is
Vishwa,
going
mute
down and the eyebrow
yourself.
is going up. So this is what we call as other Babinski sign. The first we know in the plantar, and Babinski also described this sign that if the eyelid goes down and the eyebrow goes up, there is the co-contraction. Then this is a classical sign of hemifacial spasm. And this is perhaps the last case, a child with neurodevelopmental disorder. So he is sleeping on the couch and you can see these movements almost occurring in the same manner periodically. So what is this?
Stereotype. We have an answer.
Yeah, so this is motor stereotypes. So we just need to counsel the parents. So these are stereotypes. Repeated
Excuse me,
simple
sir.
movements in
Dr.
the
Vishwa,
revolutionary
Dr.
sequence.
Vishwa, please mute yourself. Dr. Vishwa, please mute yourself. Dr. Vishwa Bhatta, please mute yourself.
नहीं अभी नहीं किया टाइम हुआ ना मैं घर से आ गई उसके बाद तो मैं तो बहुत देर मैं ऑफिस में कोई नहीं देखता रहा ना तो आज आ रहे हैं उसको
Jhankhana madam, you are host. Please mute him. Jhankhana madam, you are host.
आज बोल रहे हैं मेरे को रील्स आ रही है मेरे को ऐसे हो रहा है और सुई तो जैसे मैं लगाती हूँ वैसे में धीरे धीरे लगाए मुंह खोला था
Dr. Vishwa, please mute yourself.
हाँ ठीक है कोई बात नहीं
She's not listening. She's not responding to chats also.
Yeah, so basically they are hand clapping, flapping movements, may have body rocking, head banking, and pelvic thrusting, which we saw in the case. They resemble motor tics, but there is no driving urge. That is what differentiates tics from stereotypies. They often repeat themselves in a uniform, repetitive fashion for long periods of time. And they usually have onset less than 3 years, but in less than 3-year child, this is usually normal. But in child with neurodevelopmental disorders like autism, ADHD, etc., they may persist beyond 3 years, which are motor stereotypies. And this is a last case. You can see 1-year-old child, 2-day history of fever followed by sleep disturbances, regression and dysautonomia. She was referred to as frontal lobe seizures. What you need to observe here is she's having a movement disorder which has oromotor dyskinesia, chorioectosis, and dystonia. So whenever you see a female child with this combination of oromotor dyskinesia with dystonia and chorioectosis with encephalitic presentation, think of NMDA receptor encephalitis first rather than a viral encephalitis. Okay, so this oromotor dyskinesias are sine qua non, that is quintessential movements of NMD receptor encephalitis. So this child came to government hospital. We just did an NMD receptor antibody and she was positive and with immunotherapy. she is doing quite well currently. So this was the thing I wanted to show you, that if you have this complex hyperkinetic movement disorder with oromotor dyskinesia in female child, think of NMD receptor encephalitis in a child with encephalitic presentation. So concluding learnings of the day, not everything that shakes is a seizure. Identification of the phenomenology or semiology is the key. So semiology is the word used for seizure and phenomenology is the word used for movement disorder. So you have to identify them. When in doubt, trust history more than investigations. Still doubtful, do a video EEG in collaboration with your neighborhood pediatric neurologist. And do not miss the slam dunks like hyperexplexia with nose tapping test, paroxysmal head and eye movements in infants, which are classical for glucose transport organ deficiency syndrome and paradoxal 5-phosphate dependent epilepsy, paroxysmal tonic upgaze or downgaze with motor delay, intellectual disability, think of monoamine neurotransmitter disorders, and orofacial dyskinesias in a female child with complex hyperkinetic movement disorder, think of NMD receptor encephalitis. So this ends my talk. Thank you. I'll be willing to answer any questions if are there.
Voice. Good evening, sir. Nice lecture. I am suggesting 2 cases in last week I have seen for convulsion. Just one case is, sir, a patient having convulsion with the focal and sometimes the tonic spasm for few seconds, and patient went into the bradycardia up to 30, and the saturation is almost 20 like apneic spell. And within 24 hours, patient having 8 to 10 episode of this type of convulsion, sir. So I am referring the patient to the pediatric neuro physician. And on 7th, the epileptic patient is on 7 epileptic drug, anti-epileptic drug, and now patient is controlled, but after post-epileptic, patient having disoriented and not oriented at all, sir, and can't identify mother, father, and all the relatives. 10-month-old child is there, and before convulsion, patient is absolutely fine. Normal motor and sensory and fine development also is normal at that time, sir. What do you think for these patients, sir? Diagnosis?
Yeah, if there was a febrile event to start with, then such
No, sir. No febrile. Absolutely, patient is fine. No complaint. Only few seconds of convulsion is there of in the focal plus tonic convulsion, sir. And
so
the
in
patient,
this,
yes, sir.
Yeah, in such stormy presentation, we would think either etiologies like infectious meningoencephalitis or autoimmune encephalitis or fires like superrefractory status epilepticus. As you were saying, he was not controlled on 7 medications. So he might also be have been intubated, ventilated, may have received this midazolam and ketamine infusions and all. I am wondering like that.
Okay, sir. And the patient is a genetic study sent of this patient, and we are waiting for the genetic study for the.
Yeah, genetic is a possibility, but if genetics is a thing, then certain clues you will get. They will have some microcephaly, even if the development was normal.
No,
Some microcephaly
absolutely development is fine, but the family history of the two child having one having febrile convulsion and one having epilepsy. Both the 3 are from the same family, and two having well controlled, and this child I have seen first time, sir, this type of the patient with the bradycardia, and few seconds of the convulsion, their saturation is going down up to this, sir.
Yeah, so they are known as apneic seizures. What happens basically? The seizure focus spreads through the brainstem. And when they spread to the brainstem, they have this apnea and bradycardia. So this is classical apneic seizure. So he is at a high risk of SUDEP, what we call a sudden unexpected death in epilepsy. So he is very, that's what we have to counsel the parents, that he might just have a seizure and he might collapse and expire.
Yes, sir. I am already counseling that patient. Patient is at home for not follow up before 3 days. They came with the 2 to 3 days after that, sir. And I will explain if convulsion is occur at the home and you brought at the hospital, then and then survive. Otherwise, maybe collapse anytime at home or in hospital also.
Yes, at home also they may expire. And another thing is the 7 drugs is too much. I think the AEDs need to be optimized, because If you are giving
Yeah.
too many drugs, they may interact with each other and they may cause some
Yes,
problem to the child.
neurodevelopmental is there in
Neurodevelopmental problems,
yeah.
as well as if you give a lot of sodium channel blockers like phenytoin, lacosamide, oxcarbazepine, lamotrigine in the same child, then they may cause
Yes,
cardiac
sir.
arrhythmia.
Yes.
So that also needs to be optimized. In such patients, we usually try ketogenic diet or immunotherapy, something like that. But yeah, I need to see the child in detail to comment. But yeah, this is, I think
Yeah.
this is a
That just this is given the history, sir. Full investigation is not with me. And
yeah, yeah, agree.
another case is, sir, 3-hydroxy
Sandeep bhai,
hydroxy.
sorry to
Sandeep,
interrupt, but
Okay.
we need to have a quiz now. We are already running late in the session.
Okay. No
So,
issue. Okay.
yeah,
Sure.
sorry. Yeah. Prashant, so
Yeah. So
Sridhar
thank you.
sir, thank you so much for the wonderful session. And now Dr. Prashant will be conducting the quiz on the neurology. Prashant, all yours.
Thank
Yeah.
you.
So thank you so much, Dr. Shridhar, and I request you to stay back because few of the questions are from the today's session, which we have prepared live. So those who have attended, I think there was a good interaction while this quiz was being present. I mean, session was being taken. So coming to the quiz, I hope my screen is visible now. And before I begin, I'll request Chaitali from Zorvia, who are going to be a sponsor of the quiz. And we are thankful to Jhankhana ma'am, Nehal ma'am, Sandeep bhai, Yogesh bhai, Baldev sir, everybody, and Lata ma'am for always working hard for the e-Gurukul. Chaitali, if you are there, you can just speak for a minute and then
Yeah,
we can start.
Dr. Prashant, am I audible?
Yes, yes.
Yes,
Yeah. Yeah, thank you so much. I think first of all, it was a wonderful session. I was also there in the session for last 1 hour. I was attending this session. First of all, at the outset, let me express my heartfelt thanks to eGurukul Pathshala, which is an initiative of AOP Gujarat, on behalf of our Zorvia family. Our Zorvia family had just completed 6 months, and the journey till now has been the very encouraging with the support from all of you. I take this opportunity to thank Dr. Yogesh Parikh, Dr. Baldev, Dr. Sandeep Trivedi, Dr. Lata Cha, Dr. Shridhar Joshi, who was the today's speaker, Dr. Jhankhana Madam, Dr. Kirit, Dr. Jagdish, Dr. Nehal Patel, Dr. Jigin Shah, and special thanks to Dr. Prashant KARIYA. We at Zorvia always believe in getting associated with such academic events, and we would continue to do this endeavor in the coming months as well. So we request all the doctors to support all of us in our future journey and achieving the milestones that we have set for ourselves in the coming months. Also, I would just like to inform, within a short period of time, sir, we have also joined hands with a reputed organization like Eris Pharma to get the marketing and distribution rights for some of their brands. So this adds one more feather in the Zorvia's journey. So thank you very much once again, eGurukul Academy of Pediatrics, AOP Gujarat. Thank you very much, Dr. Prashant. Thank you so
Yeah.
much.
Thank you
A
so
special
much.
thanks to you, Dr. Prashant. Thank you very
No,
much.
thank you so much to our team AOP Gujarat, and we are starting. So more than 50 people have already joined. So we just begin because this game everybody now know, and people are waiting and they are messaging me that the quiz has to be started. So this is just a beginning for the newcomers who are joining, that we will be having this type of a question. The EEG pattern in West syndrome is. So the real question will be having a real answers. This is just for a poll. तुमसे मिलके दिल का है ऐसा हाल. All is well. इतना सन्नाटा क्यों है भाई? And full on DJ remix. So good that in 10 seconds we have a 50 answers. So Dr. Shridhar, this is how the people are answering. And as such, it is full on DJ remix that in EEG pattern of West syndrome will be there. But this is just a second example. A child with fever develops a single generalized seizure lasting 3 minutes. Diagnosis. Though the medical diagnosis is written in bracket, but छोटा पैकेट बड़ा धमाका, simple febrile seizure, नॉन को पकड़ना मुश्किल है, epilepsy, पिक्चर अभी बाकी है, complex seizure, and koi mil gaya meningitis. So good to see people are active and we are getting good number of answers. 69 or 70 people answering immediately. And the correct answer was Chota Packet Bada Dhamaka. Now the real quiz starts. All the best to everybody. May the best person win. The first question. The most common cause of a seizure in child aged 6 months to 5 years is febrile seizure, meningitis, epilepsy, brain tumor. So Dr. Shridhar, if you can see 76 answers come in 10 seconds only. And then
Yeah, great.
all of them are correct. So it is good teaching that febrile seizure is a right answer. All 80 are correct. So that is good. But the fastest finger first was Priyaraj. Coming to the next question. A simple febrile seizure are characterized by all except focal onset, duration less than 15 minutes, generalized, occur once in 24 hours. So when we are having simple febrile seizure, we usually will not have a onset which is focal. So that is the correct answer and given by majority, and it's good. So Dr. B is coming first now and leading the leaderboard. Okay. Now West syndrome consists of, this has been taught, tonic seizure with fever, focal seizure with aphasia, infantile spasm, hips arrhythmia and developmental regression, myoclonic jerks, absence seizures and ataxia. So 83 people have already answered, and I hope those who have attended today's session will be, yes. So that is Dr. Shridhar, credit goes to you that the developmental regression, infantile spasm and hips arrhythmia rightly said and people have actually understood. I would like to ask you, Dr. Shridhar, if a child is having a focal seizure with aphasia, what do you suspect?
Okay, so if you have focal seizure with aphasia, you suspect a Rolandic epilepsy in infancy, in the childhood period. They classically have this drooling of saliva, usually nocturnal seizures, usually 1.5 to 2 hours after sleep onset, and they'll have aphasia during the event. So it just indicates the involvement of the perisylvian region of the brain, which is the area which controls the speech output, left side.
And if a child is having a myoclonic jerk with absence seizure and ataxia, then what do you suspect?
Myoclonic seizure with absence jerk and ataxia, we may think of a progressive myoclonic epilepsy syndrome.
Perfect.
See
so
that.
yeah, so I mean, the options were rightly been selected by the peoples, and JD is now topping the list. Next, which of the following is not a typical feature of infantile masturbation? A preserved consciousness, facial flushing, leg crossing or rhythmic movements, and post-ictal confusion. So this was a live question prepared from your talk. And those who have attended, they are giving fast answers. 80 answers are already there, 82 now, and correct. Majority are correct. So good, again, they were attentive, and post-ictal confusion is the correct answer. Okay, coming to the next question. A drug of choice for childhood absence epilepsy is phenobarbital, carbamazepine, phenytoin, and ethosuximide. So usually if you notice, Dr. Shridhar, 80 answers are coming in 10 seconds only. Few people are only answering after 10 seconds. I'd like to ask you one thing. The right answer is ethosuximide. In today's era, what is the role of phenobarbital for which we are using phenobarbital?
Main indications. First is neonatal seizures. Whatever anyone says, my stance is clear. Drug of choice for neonatal seizures is phenobarbital, barring you have ruled out hypoglycemia, sepsis, and dyselectrolytemia. If you have a neonatal seizure, give phenobarbital. This logic of phenobarbital causing excessive sedation and all is usually not useful, because if you give phenobarbital for an indication which is not there, like hypoglycemic seizure, then it will cause sedation. But if a child with HI who has seizure, if you give phenobarbital and the seizure reduces, the sensorium should improve. Then second indication is phenobarbital coma in super-refractory status epilepticus, like fires. So we use continuous phenobarbital infusion, high dose, up to 3 mg per kg per hour in suprarefractory status epilepticus like febrile infection-related epilepsy syndrome. So these are the two indications in which we use phenobarbital in current era.
Yeah, and they should not worry about using phenobarbital in a HI patient, and that remains still the gold standard, and that has to be a first line always for that.
And the second thing is people do a lot of this phenobarbital levels. We need to understand that the half-life of phenobarbital is 96 hours. So even if you do a level, the level will come high only. So please, what I have seen in NICUs is they do a level, they see the child is encephalopathic, they think the encephalopathy is because of phenobarbital, and they stop phenobarbital, and the child starts seizing again. Okay,
So the nice message that half-life is 96 hours, so there is no meaning when you're loaded the dose and you're seeing that the child is actually remaining drowsy, and that is not because of your phenobarbital, that is because of the HI, right?
Yes, yes.
Fine, fine, perfectly fine. Okay, coming to the next question, which is a drug of choice for status epilepticus. The first line, what will you start? Diazepam or a lorazepam, phenytoin, levetiracetam, or a phenobarbital? So remember, this is drug of choice when you are giving as a first line treatment. It is like whenever a child presents in a status epilepticus, at that time, you have to give always the diazepam or a lorazepam. That still remains the choice, and 70 people are right. So that is perfect. Okay. Now we do have a Zaz as the first leader. Sitara, if I remember, she used to win the quiz. Most common cerebral palsy subtype is spastic, dyskinetic, ataxic, or hypotonic. So good to see many of you participating. And now we wish to see 100 number. This is 85 only. We wish few more answers. And the correct answer given by majority, it is spastic CP, which is the most common type of a cerebral palsy. And we do have a JD as we usually like to say JD is the topper in college days in our batch. The Kernig sign indicates what? It indicates meningeal irritation, a cerebellar lesion, a peripheral neuropathy, or a raised ICP. So good, the number has reached to 86 in 10 seconds. We need 100 people to answer. And yes, the correct answer given by majority is a meningeal irritation. Coming to the next question, which is a drug causing gingival hyperplasia. A valproate, levetiracetam, carbamazepine, or a phenytoin. Now, this is a question which we used to have in our UG days also. 88 answers and 76 are perfect. That is phenytoin. Can you say few more drugs which can be causing a gingival hyperplasia? Like anybody can unmute and just answer, because I'll not be able to see the chat while presenting this screen. So the cyclosporine is one more which can cause gingival hyperplasia.
Cyclosporine.
Yeah, cyclosporine. Yeah, perfectly fine. Okay. Yeah. Okay. Next, let's have a CSF finding in Guillain-Barré syndrome. This has to be perfect. That what is it? A low glucose, a RBC predominance, a high protein with normal cells, and a pleocytosis. So out of these 87 answers, I hope to see almost all good. Yeah, so almost all are right. That is a cytological protein dissociation which is happening, a high protein with normal cell counts which will be there, and that is one of the criteria. And now Sitara is coming back as a top. As I said, she is a regular student who is participating. A preferred imaging for suspected acute ischemic stroke in a child. A CT angiography, MRI brain with diffuse weighted imaging, a skull X-ray, or a EEG. In this, I would like to have, once the 20 seconds are over, the comments from Dr. Shridhar that when we are suspecting acute ischemic stroke, why MRI brain with diffusion weighted imaging is better than the CT. Hello? Am I audible?
Yes, you are.
Yeah. I think Dr. Shridhar is not there. So see, in acute ischemic strokes, we always want the proper structures, and giving a time for
Thank you.
MRI will be a better. So that is always the choice, and that is given correctly.
Yeah, sorry, I could not get. Sorry, I was.
Sorry, I'll just ask after this. A bilateral
Okay, sure.
periventricular leukomalacia commonly causes ataxia, hemiplegia, dyskinesia, or a spastic diplegia. So usually this type of bilateral periventricular leukomalacia which happens and that is causing a cerebral palsy, a spastic diplegia which is there. So my question was, Dr. Shridhar, in acute ischemia, why do we go for a MRI brain and not the CT?
Yeah, because this ischemia is usually seen on this diffusion weighted images.
Okay.
Yeah.
Yeah.
So
So
that's
if
why
we
it is
suspect a bleed, then
Yeah.
CT may be a choice, not the
choice.
MRI,
Yeah.
right?
No time. Yeah.
Yeah.
So
So
in
that's why.
adult strokes, they usually go adult stroke protocol is they go for a CT, and if the CT has no bleed, they thrombolize the patient. But in
Okay.
pediatric stroke, thrombolysis has just come up in 2026 guidelines. Is the first time in history where pediatric thrombolysis has been described as a level A evidence. Before this, we never thrombolized the pediatric stroke evidence-based wise. But now the 2026 guideline which are just released last month, they have given pediatric stroke also as an indication for large vessel occlusions as an indication for thrombolysis. So now we will be able to see thrombolysis in pediatric strokes also. So now urgent imaging will be the diagnosis in pediatric strokes also. So we need to be observant of the patients, and if they have a focal deficit, do urgent neuroimaging. Don't wait for 1 to 2 days MRI anesthesia patient to come. Do it directly. Consider it as an emergency because they are more treatable.
Yeah. Okay. So acute disseminated encephalomyelitis is a brain tumor, a congenital anomaly, or a post-infectious demyelitic disease, or a peripheral neuropathy. So this is just a simple initial part. Finishes our first part of a quiz, which will be a basic questions, and we are seeing a good number of participations, 85 people answering, and almost 84 out of that are correct. That is post-infectious demyelitic disease is the correct answer. Now coming to some tricky questions, which will be changing the leaderboard. And let's see. A toad paralysis occurs afebrile focal seizure, during seizure, after focal seizure, during seizure, during sleep, or before seizure. Again, in some patients of this type of a seizure, once the seizures are over, focal seizures are over, the toad paralysis will be there. And again, more than 90% people are right out of 85, and it's a post-ictal in a focal seizures. Okay. Now a double point question, a game changer question. A characteristic MRI finding in hypoxic ischemic injury in term infant involves frontal lobe only, cerebellum only, basal ganglia in thalami, and occipital lobe only. Yeah, and again, I'm happy that out of 87, 81 are right, that it is basal ganglia and thalami, which is a correct answer. Moving forward, we do have a new leader, GS, followed by Dr. B. And I request all the winners, because we are going to give 15,000 rupees prizes worth, and all 11 person has to stay till end and send their details along with the screenshot to our mobile number or email. Then we can transfer the money. Okay. Moving forward, again a double point question. Benign enlargement of subarachnoid space presents with microcephaly, developmental regression, macrocephaly with normal development, and severe spasticity. So good that around 80 people have already answered, and the right answer again given by 66, that is macrocephaly with normal development. That is benign enlargement leads to a macrocephaly, but most important thing is the development remains normal in that cases, and that is the most important thing. Okay. Moving ahead, our next quiz. somehow a child develops bilateral ophthalmoplegia, ataxia, and areflexia. The diagnosis is a Duchenne muscular dystrophy, the SMA, a myasthenia gravis, or a Miller-Fisher syndrome. So 80 people are done, and the correct answer again given by 72, that is Miller-Fisher syndrome. So that is correct thing. And good going team. We do have a few. Dr. Mohan as the highest climber. And let's see which anti-epileptic has the broadest efficacy against generalized seizure types. Phenytoin, carbamazepine, oxcarbamazepine, and valproate. So the broad spectrum, broadest efficacy against the generalized seizure type is mainly with the common drug which everybody is using. Out of 87, 66 are correct. That is a valproate.
I would like to make a point over here. This sodium channel blockers are contraindicated in generalized epilepsies. They will worsen. So never ever try a sodium channel blocker for generalized epilepsy. Always go with a broad spectrum drug like valproate, levetiracetam, or lamotrigine. But lamotrigine you cannot load. So valproate and levetiracetam are good choices.
Yeah. So I was going to ask you this question only, which you directly answered. Thank you so much. And now we do have again a new leader, Dr. B. Coming to the next question. Somehow my quiz is taking double question only. A girl with developmental regression, acquired microcephaly, and hen ringing stereotype movement is Angelman syndrome, Prader-Willi syndrome, Fragile X syndrome, or Rett syndrome. For this question, we have given a 30-second because we wanted everybody to think about this. And 86 answer, 87 are there. Come on, friends, we are waiting for the magic number of 100. So by the time the answer comes, yeah, and Rett syndrome correctly said by 71 people. I want a quick comment by Dr. Shridhar on this.
Yeah, so this is a classical triad of Rett syndrome. Usually, you see this triad and another more clinical scientist, they have this sighing respiration. They'll breathe like something like. So because of this sighing respiration, they will have respiratory alkalosis and hypocalcemia. So if this child ends up in seizure, Rett syndrome diagnosed child, usually it will be a hypocalcemic seizure first. So always check calcium in this child. And any girl child, it's a X-linked dominant disease. Girl child, the classical this washing and hand wringing stereotypies and acquired microcephaly. That means the head size at birth, let's say, is 34, and after that you may see it being on 33.5, something like that. So that's why it is known as acquired microcephaly. So the brain size may be normal at birth, and because of regression or cerebral atrophy, the brain size would decrease. That's why it is acquired microcephaly. This is what they ask in Viva, why it is acquired microcephaly. It's not a congenital. Maybe normal at birth and then it decreases.
Yeah. So perfect. But our audience is also giving a perfect answer. If you can see, out of this 90 people, 71 were correctly diagnosing a Rett syndrome, which is a good thing. And we do have a good audience. Coming to the next question. Still, it is double point questions. A child with cafe alert spots, axillary flaking, and optic pathway glioma most likely has a Sturge-Weber syndrome, Van Hippel-Lindau disease, neurofibromatosis type 1, or a tuberous sclerosis. In this also, in 10 seconds, we have a good number, 82, 85. And the correct answer in this cafe alert spot is perfectly said, a neurofibromatosis type 1. Moving to the next question. A child with recurrent morning headaches and vomiting should be evaluated urgently for tension headache, migraine only, intracranial space occupying lesion, or a raised ICP, or a sinusitis only. So this is a typical child who is having a morning headaches and vomiting. And if you find a child with morning headaches and vomiting, the most important thing to be ruled out will be a increase raised intracranial pressure or a space occupying lesion. Perfectly said. 83 people have given a correct answers. So that is a good thing. good. This is going to be a competitive quiz. I mean, we do have a good quiz. Now, 2-3 more questions which will be there, which may confuse you. Which metabolic disease improves with a ketogenic diet? If you've listened, phenylketonuria, glutathione deficiency, Wilson disease, maple syrup, urine disease. Those who have attended the lecture in the beginning, again, this was a spontaneous question which was been made. And if you attended Dr. Shridhar's talk, then you must know it's a GLUT1 deficiency. So that is perfectly said and identified. Okay. So the next question, the most common gene mutation causing Dravet syndrome is FMR1, SCN1A, dystrophin, or SMN1. So this is some genetic things which is there in a Dravet syndrome. And a quick comment once the timer over by Dr. Shridhar. Yeah.
Yeah, so yeah, SCN1A mutation causes Dravet syndrome. They usually have this fever triggered and untriggered seizures, usually with DPT vaccination at 1.5 to 2.5 months. They might go into febrile status epilepticus. And then they might have recurrent seizures till 5 years of age. And after 5 years of age, the seizures may be less, but the cognitive and behavioral problems persist. So this is the classical phenotype of a Dravet syndrome.
Okay.
Most common gene mutation is SCN1A.
Okay.
In
Yeah.
there.
Sorry, which anti-epileptic drug should generally be avoided in Dravet syndrome? So I just said clobazam, valproate, carbamazepine, or stiripentol. Now, if you have listened initially to Dr. Shridhar, you might correlate the answer which is going to come in this, that this drug should generally be avoided. And that was a carbamazepine.
Sodium channel blockers.
Yeah, sodium channel blockers. He has already given the answer in previous, so I was worried. And that's why I just rushed to a second. I thought you will be giving the answers to my next question. That's why I just rushed to a second question. Yeah. Thank you so much. Moving forward, few last questions. A Landau-Kleffner syndrome primarily presents with progressive motor weakness, acquired aphasia with epileptiform EEG, ataxia, and infantile spasms. As usual, friends, please pardon me. This last part of the quiz will be having a slight more difficult questions. And I'm giving 30 seconds for this, 86 peoples. But yes, acquired aphasia with epileptiform EEG correctly identified by 63 out of 87. So good numbers. And moving forward, the classic triad of acute cerebellar ataxia includes ataxia, nystagmus tremor, spasticity, hyperreflexia ataxia, ophthalmoplegia, deafness, neuropathy and ataxia, seizures, and coma. By mistake, I've given a one wrong answer. I forgot to remove one thing. So you can actually eliminate the ophthalmoplegia, deafness, neuropathy, and ataxia because these are 4 things, not a triad. And the correct triad is identified by 74 people. That is ataxia, nystagmus, and intention tremor. So correct. Okay. Moving forward. Which virus most commonly precedes acute cerebellar ataxia? And that is hepatitis B, rabies, dengue, or varicella zoster virus. In a day-to-day OPD practice of pediatrics, we are seeing this virus infection commonly and presenting as a cerebellar ataxia, rightly said by people, that is varicella zoster virus. So yes, correct answer. Okay. Next, which bedside test supports myasthenia gravis? It is Gover sign, a Romberg test, a Babinski sign, and an IcePack test. Once the answer comes, I need a quick comment again from Dr. Shridhar. What is this test in myasthenia gravis? And the correct answer, yeah, IcePack test. Yeah, Dr. Shridhar.
Yeah, so basically, when we put the pack of ice on the eye, so when myasthenia patient have ptosis, when you put a ice pack on the eye, the temperature inhibits the enzyme acetylcholine esterase, because of which the acetylcholine levels rise in the synapse, which leads to more binding to the postsynaptic nicotinic acetylcholine receptors and the ptosis improves. So this is one of the bedside tests which we use clinically even today for myasthenia gravis. So if you have a child with ptosis and ophthalmoplegia with diagonal variation, use this test, order AChR receptor antibodies, order a chest X-ray or CT test for thymoma, and diagnose myasthenia gravis, start pyridostigmine and steroids.
Yeah, so perfectly said. And now last three questions before we decide the winners. So all the best again. Infant botulism commonly presents with descending paralysis, spastic diplegia, hemiplegia, ascending paralysis. And this commonly is the thing which is usually we say for this things the honey should be actually be avoided. And this infant botulism usually presents as a reverse thing than the what is common in all the AFPs, that is a descending flaccid paralysis, and that is the common thing. Okay. A second last question before the winner is declared. The characteristic ocular finding in Wilson disease is papilloedema, cherry red spot, cataract, or KF ring. So we are stuck to 85 at 10 seconds. We need few more before the winner is decided. And yes, Dr. Shridhar, all 85 are right. This is very good that everybody knows that the KF ring is the diagnostic feature of Wilson disease. So 100% clap for all of them. And last question before we have the winners. Elevated very long chain fatty acids are seen in Wilson disease, DMD, SMA, or adrenoleukodystrophy. So this question is going to decide the winner. And 84 people, 5, and still 81 are again right. It is adrenoleukodystrophy. So, sorry, one more question is there. Sorry. Children with ataxia telangiectasia have increased risk of renal tumors, osteosarcoma, brain abscess, leukemia, and lymphoma. So this is now our fast last question, which is going to decide our winners. And all the best again to everybody, those who have already answered. The correct answer is leukemia and lymphoma. And before we declare the winners, I just want to know how was the quiz for all of you? Very easy, medium, or hard? Because this gives us insight about the next quiz, how it should be prepared. And thank you so much, everybody, for playing. And there is no correct answer. So it was medium quiz. I thought you people will say easy, but then yes, it was a medium. Fine. 13 find it very easy and 13 find it easy. So the winners on the dashboard, the top 3 will come first. I request again them to remain over here. MG, KS, and the winner is Dr. B. So congratulations to you, followed by Izhar, DP, and few more which we are going to give. So we are going to give prizes to the first 11, and let's see who are that again. I'm just going to present which, sorry. Yeah, so this is showing us the full report of session summary. and we can have the all. Just give me, yeah, view full report. And we have a 11. Is the screen still visible? Yeah.
Yes.
Yes,
Hello?
yes.
Yes.
Uh,
Yes.
Yeah, it's
Yeah.
visible.
So you can see the winner's name once it appears, and I'll just take the screenshot, requesting all of you to send it on our official email, aopgujarat@gmail.com, or you can just send on WhatsApp also. We'll just put the details. So actually, there were 156 participants, Dr. Shridhar, who were playing this quiz, and in between somebody will left, but then the full answers were given by almost 83 peoples, 87 peoples almost. So winner is Dr. B. Please send your name, mobile number and GPay number. Then and then we will be able to send the correct answer. Good thing is this Dr. B is 100% correct answers. Then Kavati Suru Babu 100%. If you see Vijendra was 100%, but still the 97% people correct answers are at the top, like Gayatri, Izhar, Eluri, BP, Vijendra, Shilsi, Neha, Vikas, and the last is Zaz. That is Jayashri. So congratulations to one and all. I'm just stopping the screen share now, and yeah.
Who is Dr. B? Can they identify?
Yeah, can we identify Dr. B?
Sir, they may directly have joined Kahoot, so may not
Yeah, yeah.
visible here on Zoom.
So yeah, it may happen. So every time we just say, but then Dr. Sridhar, it was good to see that so many people were giving a correct answers, almost saying. There were few who were playing on the Zoom also. So those who are playing in the Zoom, please play on the Kahoot, because I can see almost 111 messages on Zoom. So instead of playing on a Zoom, Dr. Lata has said that please answer in Kahoot. So Lata, I think we have to put the uh, reminders repeatedly of joining link that will be there. But thank you so much to Team AOP Gujarat, and it was wonderful to have Dr. Sridhar with us till end to solve all the answers. And thank you so much, and congratulations to one and all winners. Thank you. Yeah.
So thank you so much, Sridhar sir, for today's wonderful teaching. And many of us have learned so many things. Something are revising the course and something very new. But it was wonderful to take the journey through different videos so that the concepts gets cleared. Thank you so much. And thank you so much, Prashant. You are always having a sensational quiz. And every time you want it, that people should say it is either easy, but no.
No,
Mostly it
basically
is medium. So
because
you are
we
doing
need to,
great.
no, basically we are giving a prize. So actually, last 10 questions I'm always keeping a heart that I know. But then if it is medium or easy, that means people loved it. So that's fine.
Yes. So people love it, and it's always great work by you. Thank you so much. Thank you, Lata. Always there, helping the expert, helping Baldev Prajapati sir, and giving all the answers. Thank you, Sandeep bhai. Sorry for not letting you discuss the second case with the expert,
No
but
issue.
I will connect you to directly to him.
No issue. No issue. Yeah.
Thank you, Jhankhana madam, for being there. Thank you, madam. And thank you, Zorvia, for providing this platform and encouraging students. Thank you so much.
Good night.
Good night, all.
Good night. Good night.
Good night,
I
all.
am requesting to you all to register for the West Zone Pedicon and Good Neocon, which is held at the Narayani Heights at Ahmedabad on 14, 15, and 16th August. Thank you.
Yeah. Sandeep bhai, I will play that video in the next session because
Okay,
today it was late. I will play that in the next session.
no issue. No.
Thank you. Thank you so much. Good night, all.
Good night.
Good night. Good night.
Good
all.
night,
Good
ma'am.
night.
Good night.
Good night.
एक वो न्यूरोलॉजी का क्विज अटेंड कर रहा था भाई। 80। अभी आ रहा है? ये क्या हो गया? आ रहा है? आवाज नहीं आ रहा है? हेलो? क्या? अभी आ रहा है? अभी आ रहा है? अभी? नाउ? अभी आ रहा है?